The pseudoexfoliation in this 87-year-old patient who only has one eye. The other eye has been lost due to disciform scar. She also can't hear at all. That's a problem. So she keeps asking for me. So I'm going to take a moment and talk to her, and I'll be right back. Now, I don't want to hurt her at all because she's hyperesthetic, not deeply sedated. So I am injecting the intraocular lidocaine so slowly because what they feel is rate dependent. And as far as I could tell, she didn't feel anything there. And that's good. So here we go. We got a dense nucleus here, 3 to 4 plus nuclear. I put a lot of viscode in, and this is her only eye, and she's got macular degenerative changes in this. Her current refraction is about a minus 150. She really wants to read. The way to get her to read is to make her more myopic. What the cornea? Myopic eyes read better. The optical reason for that is not terribly complex. The low vision experts all know it. Suffice it to say, make a 2200 eye a minus 8 to a minus 10, and they can read small print. Make them plano and give them a plus 8 to a plus 10. They can't do it. It's too slow and painful. Now you can see some stria in her capsule here, not surprising. Pseudoexfoliation in an 87-year-old, but not marked. Now we're going to do hydrodissection. So now we're going to do some viscodissection. Wet the cornea, please. And we're going to do that for 360 degrees. We do that whenever we suspect zonular laxity. Essentially, we're creating a nuclear sandwich surrounded by viscoat, a dispersive OVD that goes out into the capsular fornix. Kind of acts like a conformer. Okay, we're going to have a dense nucleus here. We'll start off at 60% power. We'll see if we have to go higher. And wet the cornea. Chopper goes out over the equator to stabilize the nucleus. Whenever you see that silvery nuclear appearance, that's just a sign of condensed collagen fibers. Wet the cornea. So I've sculpted fairly deeply and quickly. Impale, chop. Next I want to do another impale chop, and then I want to take this segment out. I'm going to slip past it and lift it up and out. Now, not that easy to do it here. Here it comes. Good. Quadrant. Wet the cornea. Good. Sculpt. Wet the cornea. You can see how vertical the chopper is. That enables me to get around the nucleus and keep it from getting depressed as I chop. Wet the cornea. And I'm making these pieces fairly small. Quadrant removal. That piece is wedged in between the others. Let's go over here and get this one. See how I kind of coaxed that piece downward before I phacoed it? And there's a good sized piece of nucleus. We'll chop this, I think, in a second, making it smaller. So I talked about making her a -6. What, the cornea? Now, she doesn't have any -6 glasses. And this is topical in her only eye. She needs to see. So we actually have them get the glasses pre-op. So she'll be wearing those in the recovery room momentarily, as soon as we finish this. And wet the cornea. Epinucleus in these eyes can be tougher than nucleus in most of your cataracts. You can see I'm holding back the posterior capsule. Remember, Infusion Misdirection Syndrome? In a heartbeat it comes. And a little bit of nucleus left up here, and some cortex epinucleus over here. See if I can catch it that way. Now I have this subincisional nuclear wedge. Now we haven't done a lot of nuclear rotation here. See if I can encourage that piece to come out. Just kind of sneaking to the side of it, moving it over. I'm just going to be nothing if not patient to get this, because what I'm not going to do, and now I have it where I can point the port at it, what I'm not going to do is go out into the periphery or put the tip on its end and face it down toward a flaccid posterior capsule. Okay, cortex removal. So, cortex removal. Again, the classic time for infusion misdirection syndrome, especially in an eye with a lax zonule. And there is some here. I would classify it as moderate. But the kind where I'm keeping this port facing up all the time. You can see the capsule wanting to come over the edge and around the edge of the INA tip to the port. I'm going to make it harder for it to do that by putting that spatula against it. A little bit of cortex here. Got it. Now it's all subincisional with a nice infusion misdirection syndrome that I would classify as at least moderate. Spatula against the cortex, push it down. Wet the cornea to get the best view. Strip it off the posterior capsule. Not much left. A little bit, probably inconsequential. I just used the spatula to roll it up and took it up. How do I know there's infusion misdirection syndrome besides the fact that the posterior capsule was forward? Just look behind the posterior capsule. You can see the fragments. Used to call those emulsate because that's what it is. But how does it get back there? Wet the cornea through the zonule. And what goes with it? BSS. But now look how deep it is. Look at the angle of my cannula. We've overcome that. We pushed the BSS back through the zonule into the anterior chamber. But it's invisible. But that's the only possible mechanism for what we've observed here. Okay, this is a 29.5 diopter lens. It'll be a snug fit through the cartridge. wet the cornea, directed into what is now a cavernous posterior chamber, expanded capsular sac. So what we've seen is a dense nuclear phaco in a one-eyed pseudo-exfoliated eye with macular degeneration and therefore a target of -6. Got a little nuclear chip there, and we may have more than one. Take that away. We'll see if that's one over there. Syringe with BSS. Nice and still. So we'll take a minute here and make sure we get these incisions hydrated, and I'm still going to look carefully for any retained fragment. And I'm going to do that by irrigating the chamber angle. Make sure there's nothing there. Good. IOP is really fine now. And our target was -6, so that this lady with macular degeneration will be able to read much better than if she were not myopic.